Thank you, sir. So we'll be crisp and clear. Uh, Basically, this topic is actually the heart of pediatric cardiology because congenital heart diseases form the core of pediatric cardiology. And hence, as they are one of the commonest birth defects, we really require to place some guidelines or some consensus so as to do timely interventions, not be early, not be late. So we'll be very precise. Just an overview. As we know, the incidence of heart diseases, congenital heart diseases, is about 8 to 10 per thousand globally. And out of them, about 33 to 50% are critical heart diseases, and they would require some or the other kind of intervention in the first year of life. If we take the Indian prevalence, it is almost 2.5 to 6 babies per thousand births, which is obviously underestimated because we don't have that good a data. So that means we have approximately 180,000 new babies with CHDs per year. And that also means that we have about 60,000 to 90,000 babies with critical CHDs per year who would require urgent intervention in the first year of life. So that mandates for about 10% of infant mortality rate, which is because of CHDs. Now, India specific, if we see, we have about 100 to 120 comprehensive pediatric cardiology centers, about 200 to 250 intermediary centers, and about 1,000 plus diagnostic centers, which shows a gross mismatch between the proportion of patient and the facilities that we have. We also have urban clustering. That means the apex institutes and all these centers are mostly in the urban areas. The rural areas really suffer from diagnostics also. We have our own unique challenges like malnutrition, recurrent LRIs, and anemia, which add up to the morbidity and mortality. And hence, we require a separate India-based consensus for timely intervention of these CHDs. Right time, as we know, we were quite right. Proper intervention, and we saw what Operation Sindoor did, and we saw what Mr. Donald Trump went through when he did at the wrong times. So why timing matters? The aim is to prevent pulmonary vascular disease, number one. It is to preserve the ventricular function, number two, and to avoid irreversible changes in the heart. The principles of timing of intervention are primarily hemodynamics. That is, what is the QP to QS, that is the pulmonary to systemic shunt ratio of the child. How is the symptomatology? That means, is the child in failure? Is the child having failure to thrive? What is the PVR window? The PVR window means it is a window wherein before that time, if the child is operated, it would lead to reversible heart and a completely normal hemodynamics, whereas beyond that window, operation would lead to irreversible damage to the heart. Say, for example, a large VSD, the PVR window would be 6 months to 9 months. A large PDA, it would be 1 year. A large ASD, it would be 4 years, and so on. Also, the neurodevelopment, the growth, and the weight of the child are factors. Institutional expertise. So we can have institutions which are very advanced in our country, which can do TOF surgeries at the age of 2.5 months, 3 months, 4 months. And we have our own limited centers wherein beyond 5 kg or beyond 9 months would be preferable for the skill of that particular institute. So, at the backbone, we have all these global guidelines based on which we do the consensus. Too early operation or too early intervention probably would have a surgical risk because of lesser weight. Too late would lead to an irreversible damage. So the purpose or the objective is first to complete diagnose every child suspected of CHD. These guidelines are guidelines. They are for ease of management by all professionals, and hence they apply in majority, but they could also differ as per individual approaches. And these guidelines may be modified in future as cardiology evolves. Now, they have been classified into 3 categories. The class 1 means there is a general agreement. Class 2, there can be conflicting opinions, but class 2A, mostly they would be in favor. Class 2B, the efficacy would be less established, and class 3, it could be contradictory. Now, based on these preview, we would go through the common CHDs, and very briefly, we would be encountering every CHD. So Coming to ASD, atrial septal defects, we know the types: secundum, primum, sinus venosus. Coming to ostium secundum ASD, remember that any ostium secundum ASD more than 8 millimeters at birth rarely closes spontaneously. The closure of ostium secundum ASD is rare after 3 years of age, and rarely it may enlarge in size. PFO, as we know, it is a normal small defect in the fossa ovalis that nature has given. It is a normal finding in newborn. There is no need to close. There are some reports of stroke in adults, but it is all debatable. So PFO as of now is a normal finding. Indications of closure: any atrial septal defect with RV volume overload, the ideal age of closure, if the child is asymptomatic, it is 2 to 4 years, and in a case of sinus venosus type of ASD, it is 4 to 5 years. The reason being, sinus venosus ASD is much situated at the site of the SA node, and moreover, it is often associated with partial anomalous pulmonary venous return. So you would have a right upper pulmonary vein draining into the RA, and early closure would lead to a stenosis of the pulmonary vein because it is a growing age. So sinus venosus ASDs, the age is 4 to 5 years. Symptomatic ASDs are seldom found in infancy. I mean, we would have rarely a child who would be in failure in infancy because of ASD. Only 8 to 10% would be encountered in this criteria, but always in these kids, we have to rule out the associated lesions like TAPVC, inflow obstruction, aortopulmonary window, or a left-sided an LSVC. In those cases, early closure would be advised. If the child is presenting beyond all these ages, an elective closure, as long as there is RV volume overload and pulmonary pressures are in the operable range, is advised. Because an ASD is a low pressure, it's a low pressure defect, the Eisenmengerization takes very later in age. It can be as late as 30 to 40 years. The methods of closure, preferably device versus surgery, always those debates are there, but device is preferred as of now. Requisites: good rims should be there. The size approximately should be less than 30 mm. There should be no AV valve issues. The advantage: you don't require a sternotomy. You have a short stay. But the disadvantage: you can have a residual shunt or you can encounter arrhythmias. Surgery, often preferred in primum type ASDs, sinus venosus type ASDs, or wherein there are valve issues and wherein there is PAPVC. You require a sternotomy, you require a 5-day stay, but then the advantage is there are lesser chances of a residual shunt and there is a rare chance of arrhythmia. Devices: Empletzer device is the popular device which is being put. Coming to the next defect, VSDs would go in very short. Large VSDs, the RSVP could be systemic or even suprasystemic. The QPQS ratio would depend on the PVR. Moderate VSD would be defined as an RSVP about 2/3 of the systemic pressure with a QPQS ratio of more than 2:1. A small or a restrictive VSD could be RSVP, which is normal, with a QPQS ratio of less than 1.5 to 1. We know the types: commonest perimembranous, muscular, then we have the inlet, then we have the outlet or the subaortic or the subpulmonic VSDs. Natural history: about 10% of the large VSDs, if not operated, could die in the first year of life because of CCF. Spontaneous closure is extremely rare in large VSDs. In moderate restrictive VSDs, 30 to 40% may close spontaneously by the age of 4 to 5 years. The timing of closure: if it's a large VSD and uncontrolled CCF, you close as soon as possible, irrespective of any age of the kid. If it's a large VSD with severe pulmonary hypertension, you close it at around 3 to 6 months. If it is a moderate-sized VSD, you close at around 1 to 2 years of age, or perhaps even earlier, if there is a one life-threatening evidence of pneumonia in the child. For a small VSD or for a small restrictive VSD, the age is around about 4 years. So for perimembranous VSDs in specific, if it's a small perimembranous VSD, there is an aortic valve prolapse because of the defect, but there is no AR. A 1-yearly follow-up is enough for the progression of AR, and if it progresses, then you operate it. If it's a small VSD with AR already, you go for surgery directly. If it's a small VSD with more than one episode of infective endocarditis in the child, then also it's an indication of early closure. If it's a small VSD plus one episode of infective endocarditis, there are debatable issues, but they also advise for early closure. Outlet VSDs, small outlet VSDs without ACC prolapse, 1 yearly follow-up. Small outlet VSDs with RCC prolapse and no AR, you require to do the surgery at about 2 to 3 years before the valve gets damaged. And if it's, however small an outlet VSD, but if it is leading to RCC prolapse and an aortic regurgitation, immediate surgery should be done, because in future you have a risk of developing aortic valve damage, and aortic valve repair may be warranted. Leave these alone. Which VSDs can be left alone? Small muscular VSDs, small perimembranous VSDs wherein we have a septal aneurysm, or a clinically inaudible and a very small VSD wherein there is no LV volume overload and the QPQS ratio is less than 1.5. But these kids would require strict 1 to 2 yearly monitoring. The reason for leaving these alone is the recent data has shown that when you compare a normal child versus a child having these small defects, the incidence of infective endocarditis is almost the same. So there is no advantage of closing these kind of VSDs. Modes of closure: surgery, device. We would prefer surgery in large perimembranous VSDs, inlet VSDs, subpulmonic VSDs. We would prefer devices in midmuscular, apicals, Swiss cheese type VSDs, and selective perimembranous, where the aortic rim is more than 2 to 3 mm. PA banding was initially a good mode or a palliative measure, now lesser preferred, but still it is indicated in Swiss cheese or very large defects, or when you want the LBW infant to grow. These are the devices. Most common is the Emplitzer. Third one is the PDA, large, moderate, small, silent PDA. Large, significant left to right shunt, LV volume overload significant, significant PAH. The murmur here is unlikely to be heard. Moderate PDAs, LV volume overload is moderate. You have a mild to moderate PAH, there is no CCF, and you have a classical continuous murmur. Small PDAs, no volume overload, no CCF, the murmur is systolic. Silent PDA means you don't have a clinical murmur, but you have an incidental finding of PDA on an echo. So spontaneous closure in full term, small PDAs may close by the age of 3 months. In preterms, small PDAs can close by 6 months and even up to 1 year. Large PDAs rarely close. Timing of closures: large or a moderate PDA with CCF or pulmonary hypertension, 3 to 6 months is a good age. Moderate PDA, no CCF, 6 months to 1 year. If the child has an FTT, you can close it earlier. Small PDA, ideal age could be 18 to 24 months. Silent PDA, inaudible PDA, no closure. Mode of closure, it is individualized, but usually in more than 6 months of age, we would prefer devices or coil occluders, whereas less than 6 months of age, we would always prefer surgical ligation. There is no role of ibuprofen or indomethacin use in term newborns. PDA in preterms, intervene only if there is CCF. Small PDAs can close spontaneously, don't be very vigorous in treating. Indomethacin, ibuprofen, paracetamol are indicated in such kids for pharmacological closure. Right now, PCM is ahead of the rest of the two because of lesser toxicity. Surgical ligation if the above drugs fail, and prophylactic indomethacin and ibuprofen are not recommended. What is a hemodynamic significant PDA? So it's not a mere echo size, it's a hemodynamic syndrome. So when do I call it as a hemodynamic significant PDA? If the clinical parameters show ventilator dependence, hypotension in the newborn, feed intolerance, organ hypoperfusion, and if my echo is showing a large duct with pulsatile flow, the left atrium to aorta size is more than 1.5, and the diastolic flow reversal is seen in the LPA, then it is a HSPDA. HSPDA, old thinking was you need to close early. Now the new evidence says there is no clear benefit. They used to believe it is HSPDA is a large duct. It is not only about the largeness of the duct now. Treat all ELBW PDAs was the past learning. Now it is said that over-treatment has its own risk. So in short, routine early treatment or over-aggressive treatment is to be avoided in PDAs. Apply a conservative approach and treat only when there is hemodynamic compromise in more than 2 weeks of newborn. So coming to the other defects, AV canal defects, we have two. Either it's a complete AV or it's a partial AV. For a complete AVCD, the surgical age would be 3 to 6 months. You could do it even earlier in trisomy 21 or a child having refractory CCF or a failure to thrive, because complete AVCD has a very high chance of Eisen Mengerization in the first 6 months of life. The surgery could be a 2-patch versus modified single patch. PA band has no role here, and the aim there is lung protection. A partial AVCD, which would involve a primum ASD and a 2 distinct AV valves, the surgical age would be 2 to 4 years. Early only if there is a valvular regurgitation, and there the aim is valve protection. Obstructive lesions, coarctation of aorta, if there is LV dysfunction, CCF, you immediately intervene. If there is normal LV function, no CCF, mild hypertension, you can do it at 3 to 6 months. If there is normal LV function, no CCF, no hypertension, do it at around about 1 to 2 years of age. Modes of intervention, more than 6 months, you do a surgery or a balloon dilatation. Balloon dilatation preferred on later ages. You do a surgical repair if it is less than 6 months, especially newborns. You do a balloon dilatation with stenting if the child is almost 10 to 12 years and above age. Coming to the other defects, aortic stenosis, valvular AS in infants and older children. If there is LV dysfunction, immediate balloon aortic valvotomy, irrespective of gradients, needs to be done. If it is normal LV function, do a BAV only if the gradients are more than 80 or peak gradient is more than 50, if you see ECG changes of STT, or if there are symptoms. In neonates, do it if the neonate is symptomatic with LV dysfunction or the gradients are more than 75. If it is a subvalvular PS wherein you find an aortic membrane, then a surgery would be required. Valvular PS, if there is RV dysfunction, an immediate intervention irrespective of gradients. If the RV function is normal, you do a BPV if gradients is more than 60. Tetralogy, again a common cyanotic CHD. We know the components, important points, indications, absolute indication. Any saturation 80 and 85 below that is an absolute indication of TOF repair, irrespective of any age or weight. Even a single hypercyanotic spell is an indication of urgent intervention in a TOF. If the child is a failure to thrive and has severe RVOTO, that becomes an absolute indication. Relatives, if the saturation is progressively deteriorating, if there is a progressive RVH, if there is PA hypoplasia. Stable patient, complete intracardiac repair, single stage is today's scientific gain. So stable patient, 3 to 6 months is a good age where the child should have an adequate PA growth. Early repair, that is by 3 months, if the child has severe cyanosis, frequent TET spells, duct-dependent TOF, or a TOF with PA. So in all, a surgery in less than 1 year would have an excellent survival for the child. Neonatal repair of TOF is controversial and usually not encouraged still across the world. Complex versus palliative, complete versus palliative, you now do a complete, which is a gold standard nowadays. Palliative is only in conditions where it is an LBW who cannot sustain such a high-risk surgery, if it's a small PA size, if the complex coronary anatomy exists. In those cases, the palliative would be you go for a modified BT. Now, the advantage of sending early newborns is you do a PDA stenting. So it's a very, very less riskier a procedure. So in short, the global trend is staged repair is now going down, and a complete primary early single stage repair is taking the stand. Okay, we'll skip off this. So all TOFs would need surgical repair. Stable with minimal cyanosis, that is saturations maintaining near about 80 or more, ICR at about 1 to 2 years. If there is severe cyanosis, less than 70% saturation despite therapy, less than 3 months, you do a modified BT, more than 3 months, depending upon the anatomy, a single stage repair. We won't go into these conditions because they are relatively uncommon. Transposition, again, relatively encountered by us. 3 combinations commonly: TGA with an intact septum, which is a surgical urgency; TGA with a combination of some admixture like VSD or PDA; and the third one would be TGA VSD PS. So, timing of surgery in TGA intact septum. If the child is less than 4 weeks, arterial switch is the gold standard. If the child is already more than 4 weeks, you assess the LV size, you assess the stability of the LV, and then go for surgery. If the child presents late, then a Senning or a mustard by 3 to 6 months is offered. Neonatal arterial switch is the gold standard in TGAs. If you have a TGA with a VSD PDA, less than 3 months, you do an arterial switch plus VSD closure. If you have a combination of TGA, VSD, PS, you do a little later, that is a Rastelli surgery at about 3 to 12 months of age. TAPVC, again commonly encountered by the neonatologists in specific. We know they are supracardiac, cardiac, infracardiac mixed. Infracardiac by default is always obstructive. Timing of intervention, any obstructive TAPVC, it's an urgent intervention indication. In all non-obstructive TAPVCs, you preferably go to beyond the neonatal age, but not more than that. So the ideal would be 6 to 8 weeks, depending upon the stability of the child. PGE1, this is the only condition where PGE1 is relatively contraindicated. The exception is infracardiac, because infracardiacs are obstructive, so it could have a little benefit. Truncus, a total repair using RV to PA conduit. Truncus should be operated as early as 1 to 1.5 months age, because they go into severe failure. It's a high cardiac output condition. Total repair, wherever it is not possible, we should do a PA banding. So the modern themes of today, there is a shift towards early intervention in order to prevent the PVD, have better neurodevelopment. The modern themes go to catheters more than surgeries, prefer more of devices than surgeries, prefer hybrid approaches like in HLHS, where instead of a straightaway Norwood operation, you would go for some palliative procedures. And timing should be based on modern imaging technologies like the MRI strain, the echoes, the biomarkers, the BNP biomarkers, etc. And now with the emergence of AI, people are also trying to find out the AI scoring systems for PDAs and specific CHDs, which would help us. So, take home with love in a true sense, because this is the last talk. Timing is physiology driven, it is not age driven. The window of opportunity matters. Treat the baby and not the echo. Not every lesion requires immediate closure, as like the PDA. The catheter-based therapy has taken over surgeries gradually. Advanced imaging refines the timing of intervention, and individualization of every baby with every CHD is the key to success. So go timely, not too early, not too late. Thank you all. I love you all.